I'm Hyo-Sookim.
Please go ahead.
My collaborator is Dr. BK Koo, and Dr. Han-mo Yang, and Dr. Jung-Kyu Han. Okay, before going to the second case live demonstration, I'm going to show you the final essential results of first case. Can I see the picture of the yeah.
이쪽 안에 화면에 저쪽에 보는 슬라이드
학회장 화면,
학교장 화면을 보여줘야지 뭐하노?
패널 화면만
Can I see the main screen?
아까 분명히 얘기했잖아요.
Okay, we can see the image, the first image, first shot.
No, I can't see, so I cannot explain. What I see is just the face of Dr. Seok Hong.
Here is. Yeah, Dr. Kim, here is.
메인 스크린 보여주라니까. The cameraman in the hotel should project the main screen for us to see the main screen image. Can you see the baseline angio on the main screen? Yeah,
Yes.
okay. You can see the severe stenosis through left main to proximal LAD and circ, heavily calcified. Thus, I performed rotor ablation from left main to proximal LAD. And after a series of balloon inflation, then I stented using Onyx 3.5 and 2.75 from the left main ostium to mid LAD and circ, proximal circ, until distal. Next angio. This is the final angio after stenting. Provisional T-stenting with tap technique. And you can see the, is this final angio? Okay. Please see the
Angiographically looks
IVUS.
great. If it is available to the IVUS, is very helpful for the educational purposes, particularly in
okay.
the bifurcation region.
This is circ IVUS. You can expect the IVUS finding after T-stenting using tap technique.
Is there the run from the
Well
LAD to
expanded.
the left main or
This is a left main bifurcation. A little bit strut is protruded from the circ to left main. Once again, 다시 들어보세요. Left main ostium 언저리. 아니 그 circ ostium. Yeah, here. Play again.
One.
Proximal circ. This is the bifurcation. We can see a little bit strut protruded to the
Right.
left main. That is associated secure coverage of circumflex ostium. This left main MLD is more than 3 on the heavily calcified left main. Left main ostium is well covered by strut. Okay, next is IVUS from proximal LAD.
Next IVUS should be the circ from the left main, right?
Okay, this is LAD to left main. MLD is 3 or 2.5 in the eccentric lesion. We can see the heavily calcified wall, well expanded up to 3. Okay, left main ostium. Can I see the bifurcation lesion? Bifurcation site? Where is bifurcation? Here. No? Play again. Here. This is left main. Okay, after rotabulation and repeated inflation with various kinds of balloon using NC balloon, then we perform a T-stent technique using TAP technique. So this was the summary of the first case. From now on, I'd like to present the second case. Slide, please. Slide. Okay, next, please. This is a live case for LOTUS TAVI, a 74 years old male, chief complaint, chest discomfort on exertion, class 2 since 1.5 years ago, plus, emphysematous lung, plus, LVH on EKG, plus. Risk profile is low, just 2%, plus, but severe stenosis. Mean pressure gradient is about 60 torr, maximum pressure gradient over 100 torr. Area is less than 0.6 square centimeters, plus. Annulus is 20 millimeter, Valsalva 30 millimeter, good, plus. T, we can see severe degenerated tricuspid out valve with moderate degree of calcification, plus. Size, annulus 21, Valsalva 28, plus. Coronary angiogram shows unremarkable finding. Coronary is okay, plus. Plus. Arterography shown mild AR with moderate degree of calcification around aortic annulus. Best angle was just simple AP. Plus. Aortic femoral system is very good, plus. Total aorta looks good, just mild atherosclerotic change without stenosis, plus. Right system, good, plus. Left system also good, plus. Aortic arch looks fine, just mild sclerotic change, plus. The transverse section at the annulus level shows moderate degree balanced calcification on aortic valve, plus. We can predict the leakage by analysis of aortic annulus calcification eccentricity. Not only important, the total calcium burden is also important, but more important thing is eccentric calcification. The patient volume of calcification is 540 and 160 eccentricity in traditional method, leaflet-based method, and 160 also newly proposed by partition method. All values are below the cutoff value, suggesting this patient has a very low risk of post-TAVI leakage. Plus, but the problem in these patients is substantial amount of calcification at LVOT. That is really important risk factor for leakage and tear after TAVI. Plus, size, to summarize measurement, size 20, 21, 26, height of coronary ostium 16, 10, perimeter 73, area 394. Thus, area-derived diameter is 22.4, perimeter-derived diameter is 23.2. That corresponds to 23 millimeter valve LOTUS with oversize index just plus minus 1 or 2%. Plus, we prepared two discussion points. The first one is TAVI in low surgical risk. Hyo-Soo valve pivotal trial demonstrated that TAVI is better than SAVI in all-cause death at 1 year and then plus 2 years. In this Hyo-Soo pivotal trial, there is some percentage of patients with intermediate risk and even low risk. Now, they launched Medtronic low-risk RCT to test TAVI and SAVI in patients with low surgical risk. Plus, how about Edwards? in partner 2A trial, they demonstrate TAVI is better than SAVI, at least in transfemoral cohort. On panel D, you can see TAVI is better than SAVI in terms of death and stroke, up to 2 years. Plus, in subcohort analysis, you can see the patients with low SD score, below 5, still the results favor TAVI than SAVI. Thus now they launched partner 3 RCT to test TAVI versus SAVI in patients with low surgical risk. Plus, the third evidence is NOTION. Plus, in NOTION 1 trial, they compared plus 1 year total mortality between SAVI and TAVI. No difference because of small sample size, but actual digit is lower with TAVI. Plus, important thing is about more than 80% of these patients were low risk. Thus, they launched NOTION 2 trial to compare TAVI and SAVI in patients with low surgical risk. Plus, this is ongoing 3 clinical trials for TAVI in low-risk patients. The first one is Medtronic low-risk RCT. Plus, second one, Edwards partner 3 RCT. Third, NOTION 2 RCT. Plus, actually, in current status, in Europe market, about half of the patients were low or intermediate surgical risk. This is current status. Plus, thus, my thought is here, current criteria for patient selection TAVI is heavily based on surgical risk. But surgical risk is not anymore guidance. Patient age, expected survival, quality of life, and patient will is very important factor for us to decide TAVI. Plus, the second discussion point, which valve should we choose for these patients? In these patients, the only concern is alveolar calcification. That is associated with risk of leakage or tear. But this patient is very good aortoiliac system. Thus, I think LOTUS system is very appropriate for these patients because the efficacy of LOTUS valve is very excellent. Trade-off is a thick, rigid delivery system that requires is really good aortoiliofemoral system. Thus, for these patients, I chose LOTUS. Okay, can you see the today's angio? Thus, I punctured the fluoro-guided femoral puncture plus. This is today's root arterography, AP, just the AP view was best to align the 3 cusps at a single plane plus. So I advanced 18 French sheath. Actual out diameter is 22 French. We have to be very cautious to avoid the damage of the aortic system. But this patient is very excellent aortic system plus. Then I put the straight wire into the left ventricle and then plus advanced and plus diagnostic catheter into LV plus. Then put the wire with curved end, exchange the catheter with the pigtail plus. And now we put the pigtail in left ventricle and measured the pressure difference between aorta and LV. Can you see the pressure profile? Pressure profile 좀 보여줄까요? Peak pressure of LV is about 240. Aorta is 220. The pressure gradient is about 140. It's very severe AS. Then we are going to start the procedure. And please make a comment or question.
Okay, may I
While
ask
I
about the
proceed the
STS
process.
score of this patient? STS score?
2%.
What is the main
Low risk
obstacle of this patient for the TAVI procedure? The clinical presentation is, as you said, is a low risk patient. So therefore, the peripheral anatomy is quite clean and favorable to the sheath delivery, and the anatomical feature is also very clean and really. For the aspect of the TAVI procedure, it should be a very simple lesion.
The basement of decision of TAVI for these patients is he strongly refused SAVI.
Oh, I agree.
That's the reason why we perform TAVI for this patient.
And now this is a 74 years, the male patient, relatively quite healthy and the low risk of the ST score.
Best angle.
Only the
I don't
severe
like
aortic
the curvature
stenosis.
of stiff wire.
So you have to do
Once
this
again.
TAVI procedure should be successful without any complication. If something happen, the surgeons may blame the result of some complication because this is a low risk.
I'd like to put the stiff wire in ideal orientation, but it is a little bit difficult in this case. Always like this.
Is
Okay,
that a
let's go.
safari wire or
Best angle? Yes. Best angle. It's not good. Average life expectancy of Korean male is 78 years old. This patient age is 74 years.
will you do the predilation of the aortic valve? Predilate or direct?
Sometimes we use pre-dilatation.
In this
The
case,
first situation is when the aortic annulus size is a little bit ambiguous. Then we perform pre-dilatation to assess the actual annulus size and decide the final valve size. And if the stenosis is very severe, then we perform pre-dilatation when you use a SAPIEN system. But in case of self-expandable valve, LOTUS and evolutol, it is covered by sheath. It is very slippery. Thus, usually we don't need dilatation for the passage of valve into LV.
okay. The another
So
advantage
I-
of the LOTUS
now I
system
put-
is
I
the
push the
hemodynamically
system
stable
into the
during the
system.
deploy the LOTUS valve.
요거 좀 보여줘야 될 텐데.
이쪽, 아니,
And there is a question from the
카메라
audience.
됐습니다. 됐어.
16 millimeters of the for the
Okay.
left
그거
and
다시
10
좀
for the right.
풀어줘요.
때려요.
Yeah, 10 millimeters.
Use a microphone.
Yeah, it's not.
Height of left coronary ostium is only 10 millimeter. So is it enough for
Yeah.
LOTUS valve?
That is a kind of concern.
Good comment.
Would you protect the left main,
This is
Dr. Kim?
retrievable system. When there is this is retrievable system. When there is obstruction of left coronary flow, then we have to recapture the system and put a coronary guided catheter and then deploy the valve. And if necessary, we have to do left main stenting.
We strongly
please,
recommend
let's,
the participation from the
observe
floor.
the-
If you have any question or comment, to use a microphone, please join us.
Okay. This is very important step because delivery system is very rigid and thick. it is frequently associated with aortic damage. So it is very important to trace all the aortic wall when it passes through. Table. Okay.
I think his comment is good. Please slowly and comment and every tip for the lotus valve deployment. It is not a predilation.
Okay. 저장했어요.
Could you show us the hemodynamic status
Then we are going to deploy.
during the deployment of the lotus valve?
아니 프레시 보여달라고 올려달라고 맞죠.
Another view는 헤모다이내믹 모니터를 보여주라는데 손 보여줄 필요 없고 헤모다이내믹.
Everybody wants the hemodynamic status during the deployment
Okay.
of the.
오케이, 됐습니다.
테스트.
테스트하겠습니다.
Now I adjust the lower edge of post at the annulus. Deploy start.
deploy,
Unsheathing started.
deploy, deploy,
He will try to move the marker should be at the center of the pigtail.
deploy,
테스트.
deploy, test,
테스트.
스탑. 저장하고. 오케이.
갑니다.
Deploy.
deploy, deploy, deploy,
테스트.
테스트.
Okay, still 저장하고. Three post ends corresponds to annulus plane.
Still, there is no change of the hemodynamic
Deploy.
status.
deploy, deploy, deploy,
Stop.
stop,
Test.
테스트.
A little bit high on the right side. Okay. Just in it, please. Shoot.
다시.
Do we have to capture? No. Just push it.
캡처를 해야 되지 않을까요? 이쪽은 뒤로 올라가 있네.
네. 지금 3포스트를 싱글 플레인으로 하면 돼요.
코달,
I'd like to make the 3-post at a single plane. Okay.
Okay.
Stop.
스네,
Snap once again.
네,
It's acceptable. Okay, how about the indentation? So, is it possible to do a layover process in this stage?
You have to consider that there is a shortening when you proceed the lotus valve implant. There is some the possibility of the left side
손 안
one.
되네.
Be cautious.
Just I perform a layover process to push the whole system a little bit. Okay,
Good,
this looks good.
Good.
How about further deployment? Okay, okay,
알겠습니다.
deploy.
deploy, 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 deploy,
During the
Deploy.
deployment, there is
Valve
no
frame is
change of
already
the
fixed.
blood pressure.
deploy,
Stop.
stop,
Test it.
테스트.
How about coronary flow? Maintain.
Looks good.
저장. Good. Okay. Let me show you the cine view. Shoot.
You have to continue the layover, to continually push.
No, it's just okay.
Are you sure?
Ready?
예스.
Okay. Once again, cine. Shoot. It's good.
Looks
Depth is
okay.
good. Thus, I proceed the process continuously. Okay.
deploy, deploy,
Just 5 minutes. Eh?
deploy. 예, 여기서 리딩 어세스먼트 하죠.
Okay.
오케이.
Now the time to do a lead-in assessment. A little bit high, but it looks good. Right fork is good. 좀
네,
돌려보세요.
조금 뒤쪽으로 좀 돌려보세요.
lead-in assessment is very important to check the alignment of post, buckle, and collar. Table.
하나는 완전히 괜찮고.
How about? 네.
X는 보시죠. 네, 두 개는 네,
Two right two are good. How about the left one? Also good.
네, 괜찮거든요.
Looks okay, but we cannot check it. The two right side is okay, but the left side one pretty sure that the other view.
Left side is
네.
okay.
Okay.
네, 좋습니다.
But I'm concerned about height. It's a little bit high.
I agree. In this
Okay.
view,
Just best another angle, previous angle. It's very high in this angle. Test it.
and second one is the central marker does not
Test it.
position in the center of the pigtail. It means that
Okay,
there is
just progress,
additional
proceed
shortening
more.
of the valve.
Until locking.
천천히 가겠습니다.
I'm going to proceed the process until locking. After locking, there is no change of shape of valve. Slowly, slowly, slow is very important. Stop. 앵글 좀
저쪽으로 좀
바꿔주지.
돌려주세요. 에레어로.
좀 센스 있게 해주지. 너무 많이 했다.
아니, 좀 풀고 조금만 돌리면 돼.
조금 더. 조금 더. 오케이, 카우더 맞추고.
One of the comment is
제가 좀 비켜주게 해줘.
toward
조금 더.
the echo
Okay,
TE to
자,
the
테스트.
distal margin of the
Sure.
lotus valve.
How about it?
네.
Looks like
I think
some
it is too high at
Yes.
this angle. Thus, I recapture the system to adjust the implantation depth. How many minutes are remaining? 1분 45초. I can show you recapture process for the next 1.5 minutes. Okay, slowly recapture.
네.
Very good.
나왔어?
네, 점점
Will
밀려나.
show us the hemodynamic status of the.
To implant as high
Okay.
as possible.
노즈 오픈. 오케이.
Okay.
This is a very good demonstration for the
스쿼트가 몇 세트라고?
reshaping the
다시 한번.
lotus valve.
Recapture the system and readjust.
Okay.
Okay, start.
모양 좀 보여줘 봐봐.
Test.
테스트.
At this status, we once again repeat the deployment process. Okay. Start. Deploy.
Deploy. Deploy.
Thank you.
Deploy.
Mike.
네.
Okay, Dr. Kim, I think Dr. Kwon is waiting for us to go to his case.
I
We
think-
will come back to you.
Okay.
I think
with
this
the
is a
result.
very important. It's a real live cases.
제자.
And after the deployment of this case, and then we will move that.
Okay.
This is a very interesting and educational for
Okay.
the
Good,
all
good
audience.
idea. Okay. Good idea. Deploy.
Deploy. Deploy.
Now the marker is moving to the center of the pigtail. It's a very good sign.
Deploy.
Test.
테스트.
Store.
Dr. Kim, I think it's very too low. Do you think
갑니다.
the position is
Deploy.
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 Not too low.
maybe?
쯤에서 오버레이 하시면 돼요.
Test.
So far, it's good. Go
That's
ahead.
good.
Go ahead.
Then I perform overlay by push hold the system.
Go ahead.
Okay.
And the final
little bit
deployment, there
lower.
is some shortening of the
Push.
lotus valve.
네.
Deploy.
Deploy. Deploy. Deploy. Deploy. Deploy. Deploy. Deploy. Deploy. Deploy.
Test.
여기서 리딩 어세스먼트 하시면 돼요.
Test.
테스트. 여기 씬 한번 찍으면 바로 되겠는데? 두 개가 다 포커가
오케이.
되니까. 여기서 씬을
Thus, we are going to do lead and assessment.
looks
Cine?
like the angiographically is
Okay, it's
acceptable.
good.
Why don't you give us the
Okay.
TE image in this status?
Okay.
네.
Deploy.
디플로이.
We don't have time because the time is very limited.
자,
Okay,
천천히
just
갑니다.
straight go ahead to the locking process.
There is some indentation in the both side, particularly in the around the
Very,
marker. It's a
very
good sign
slow,
for the
slow.
anchoring lotus
됐습니다.
bell.
됐습니다. 좋습니다.
Okay, Cine.
Looks good.
네.
There is a more
Okay, left main
shortening.
flow is good. It's better than the previous one in terms of depth.
Right.
많이 돌려야 돼. 많이 돌려야 돼.
I think this status is
돌리세요.
quite acceptable. Don't try to the too high deployment.
Counter. Okay, 됐나?
오케이.
Okay,
네. 좋습니다. 네.
which one? Left
왼쪽,
one?
왼쪽,
Okay,
예.
good. Minus. This is a previous Cine. Two rights are okay. Next, plus. Left one is also okay.
I'm not sure.
Previous angle. I'm not sure. Okay.
조금 더 돌릴 수 있나요? 여기 아래로.
We have to
Maximum,
focus on the
네. 그럼 에러로
close contact between buckle and post. This
네.
is locking process.
에러 돌리세요.
Can you magnify the
에러로
images
갑시다.
more?
I don't like magnifying.
조금 더 돌리세요. 에러요.
For the educational
조금 더.
purposes.
Okay.
오케이.
좀 올리고.
네. 됐습니다.
Once again, Cine.
오케이.
No gap.
네.
No gap between buckle and post. Thus, I think locking process are all verified in 3 sets.
Okay.
Okay.
오케이. 가시죠. 자, 앵글 여기서
Angle.
갈까요? 아까 그 잘 보이는 앵글로 갑시다.
And right now, you
Just
are
angle
planning to
down.
release
Okay.
the LOTUS
Okay.
system.
오케이. 자.
Yeah,
자,
now
hard
time
stop까지.
to
네.
a hard stop.
네, 됐습니다. 텐션 릴리즈.
Before releasing
자,
that,
진행해
볼게요.
why don't you use again TE
오케이. 좋습니다.
and
That's
confirm
good.
it.
Depth is good. And there is no conduction disturbance on the ECG.
자, 그
Okay, we're going to. Can you see the T?
No. Please show us.
오케이. 큰 화면으로 보여주세요.
큰 화면으로 T.
Okay, looks good.
오케이.
Distal margin is quite acceptable. And when we look at this image, we have more confidence about
Transverse section.
the TAVI procedure itself.
We can see the coronary flow at the 12 o'clock. Transverse section.
I think that the coronary flow will be visualized by the angiogram more sufficiently.
Okay, there is no paravalve leakage. 12 o'clock flow is coronary flow. Okay, angio once again. angio로 바꿔주세요. 올해는 영등.
In a previous the angiogram, the definitely the
메인
coronary
화면에
flow
angio를
is
띄워달라고.
the above the lotus bell.
Okay, we are going to release. Okay,
자,
release,
페이즈 온 릴리즈 합니다.
release one.
Agree.
Can you notice
Yeah.
the movement of central pin?
Please slow. Everybody is
Can you show us the
watching it.
hand?
Okay. Release second phase, please. Release second phase. Please check the mandrel.
There.
Okay. Okay.
오케이. 네,
오케이.
됐습니다.
So we are going to enter the step of retrieval. Then 저장.
네, 됐습니다.
Angio.
Okay. Then for the retrieve of the system, 자, 내가 잡고 있을게요.
알겠습니다.
Y 좀 나왔다.
네. 네, 여기서
오케이.
협착하겠습니다.
Retrieval the system. Y 나옵니다.
네. 네, 됐습니다. 네, 됐습니다.
오케이. So Y stay.
네, 와이스 됐습니다.
하지만 그렇게 이렇게.
네, 그대로 나가겠습니다.
자, 이거 놔두고 요거
Before
픽테일
that,
들모.
please show us the
Thermo.
angiogram.
Okay, I retrieved the pigtail pinched in the
Thermo.
sinus, then perform root arterography to check the leakage
엔지오 준비됐죠?
by angio.
T 좀 빼주세요.
Personally, this LOTUS procedure is very educational and for the beginner, and slowly we can learn the LOTUS system delivery and
Aye.
deployments.
다이 맞아.
네, 맞습니다. 자, 컨트롤 세우고.
오케이.
쓰네.
쓰네.
준비.
Sure. Okay. A little bit regurgitation. It may be
Central,
associated with wire. Okay. 그거 좀 할까요? 빼고.
네, 자, 빼겠습니다.
I exchanged the stiff wire with the pigtail in left ventricle. pigtail.
이렇게 해주세요. T는 어때요?
AV conduction is really good. I'm happy.
별로 안 보입니다.
T에서는 리거지테이션이 없는 거죠.
자, T 보여줄까요?
화면 T 바꿔주세요. 네.
Please give us a long axis.
I exchanged
Long axis of T
The
image
stiff
is
wire.
highly appreciate.
Dr. Kim, the Samsung Medical Center finished their cases. We moved to the Samsung Medical Center, and then you come back soon.
엔지오를
Okay.
한번.
이거 스테이션 안 보입니다.
Dr. Won,
를 다시 한번 할까요? 어차피 가는 거니까.
Dr. Won.
맞습니다. 네.
Dr. Kim, we are
Yeah,
back.
this is the previous angio. We can see the moderate regurgitation because of stiff wire bias. Stiff wire is inside. Usually there is significant transfemoral regurgitation due to the stiff wire. Then we exchange stiff wire with pigtail plus no regurgitation.
Beautiful.
Thus, that's a very important different point between LOTUS and SAPIEN 3 in Samsung Medical Center. Samsung Medical Center, we can see mild degree AR, even though there is outside fabric of SAPIEN 3. But outside fabric is different between SAPIEN 3 and LOTUS. In LOTUS, no regurgitation. T, please. T 메인 화면으로. There's no paravalve leakage. T. Then hemodynamics. You can see the hemodynamic feature.
아직 안 나왔습니다. 아직 안 나옵니다.
Previously, pressure gradient was about 140 millimeters of mercury. No pressure gradient between LV and aorta.
왼쪽.
Aortic pressure, pulse pressure is very narrow, suggesting no regurgitation. Thus, AR index is about 34, well above 30. It's an excellent result. Then we are going to remove the LV pigtail and show you final angio. angio 메인 화면으로. 테르모 좀 줄까요?
들어보세요. 컨트롤 좀 채우고. 예.
오케이. 신의
진행
준비.
준비됐죠?
Ready?
It is very important to make the valve tangential with adjustment to projection angle. That is very important. Cine. Shoot. Okay. The other angle.
Very good result. No PPR at all.
Caudal.
고달.
Caudal.
Maybe trace.
No trace.
More caudal to make the three posts in a single plane. Okay.
네.
Okay, once again, Cine. Ventricular depth is ideal because there is no conduction abnormality. The only trade-off LOTUS is high incidence of complete AV block and high implantation rate of permanent pacemaker. Thus, we try to implant LOTUS valve as high as possible. Minus, okay. This patient's age is 74. Probably expectation of remaining life is about 10 years. Then I expect this valve maintain until 10 years. In this clinical follow-up data, there is evidence to support durability of TAVI valve leaflet at least 7 years in the Vancouver registry of Edwards valve that uses bovine pericardium. LOTUS also used bovine pericardium. Thus, I can think the durability of this LOTUS valve may be not inferior or maybe superior to the core valve, which uses porcine pericardial tissue. If it fails, unfortunately, we can deploy another TAVI valve as a VIV strategy. Thus, if we even live longer than 10 years or even 15 years, we can manage these patients with TAVI. I think the surgical risk is not anymore indication for TAVI. The true indication for TAVI is age. Thus, when TAVI valve leaflet durability is confirmed, the prototypic therapeutic modality for AS would be TAVI. Thus, we have to wait for the durability of TAVI valve leaflet. And industrial partners really put their investment to prolong the durability of TAVI valve leaflet. In the previous year, before launch of LOTUS, if patients have a significant amount of calcification at LVOT, it is inevitable to see the significant amount of paravalvular leakage. But with adoption of LOTUS system, this patient has a significant amount of LVOT calcification. But we can treat this patient without leakage. The trade-off is very difficult technique to deploy the LOTUS valve in optimal status. The first one, we have to choose the appropriate size. Second one, ventricular depth is very important. Third one is safety issue, especially for the aortic wall, because of thick, very firm, rigid delivery system. Thus, if we accustomed to technique, we can manage most of the patients with LOTUS system with perfect results. But the trade-off is always AV block and aortic safety issue. Thus, with the launch of new edge system, we can more easily treat AS patients with perfect results with LOTUS edge system.
One size
It's
means
good
one
comment.
bottle.
We have 3 available TAVI system in Korea: Evolut R, Sapien 3, LOTUS. In terms of leakage, LOTUS is perfect. In terms of safety, Evolut R, LOTUS is better than Sapien, especially in coronary obstruction or aortic tear. But LOTUS, compared with Evolut R, the system is too big, too rigid, while Evolut R is very shallow, flexible. It's very safe. But leakage is more common, Evolut R, because there is no mechanism of outside fabric to prevent leakage. Thus, if the patient is very old with very poor aortoiliac system, then we can use Evolut R, the safest one. But if you pursue the perfect results because the patient is young, then we have to pursue more appropriate device such as LOTUS. Sapien 3 is very good device, especially in patients under emergent status or hemodynamic instability, because we can finish the procedure just 15 seconds with Sapien 3. Thus, in our system, we usually use TAVI, but in case of poor vascular access or extreme size, then we use Evolut R. In case of emergent case, poor hemodynamic status, we usually Sapien 3. Just finish the procedure within 30 seconds. That's our team's principle, to choose one TAVI among 3.